have our last session of the day, the HIT panel, and a man that needs no introduction, Mr. Joe Carr. He's the CIO at New Jersey Hospital Association, on the event planning committee with New Jersey HIMSS, and a board member of New Jersey HIMSS. Joe?
Well, you guys are still hanging strong. It's good to see it. This next portion of our program, we really felt it important. As you guys know, an important part of becoming meaningful users for a lot of our providers is the dedication and help of our vendor community in terms of this effort. So we thought it'd be really interesting to kind of hear from them today. So what I'm going to do, the format today, pretty simple. I'm going to introduce each member of our HIT panel. They're going to come out and do a brief introduction about themselves and their organization. And share what they'd like to share. And then after we get done that, then we're going to sit down and we're going to have a little Q&A. Sound good? All right, so let's start off with, I'd like to introduce Barbara Hobbs. She's the Manager of Electronic Health Records and Federal Initiatives from Meditech. Barbara is the Manager of Electronic Health Records Initiatives for Meditech and is responsible for overseeing all the federal initiatives, standardization, certification requirements for the company. As part of our position of keeping up to date, analyzing emerging industry standards and regulatory requirements, Ms. Hobbs also has collaborated with many industry work groups, including HIMSS EHR Vendor Association, HIMSS Government Relations Special Interest Groups, HL7 EHR work groups, IHE Patient Coordination, and E-Connecting Communities. Barb has over 25 years of healthcare experience in various clinical and management settings. Her 15-year tenure at Meditech includes implementing clinical applications such as nursing, order entry, EHR, EMR, electronic medication administration, and computerized physician order entry. So as you can see, we've got the right person for Meditech here. Barb?
Thank you. Good morning, everyone. Thanks for having us. As Joe mentioned, we really are pleased to be here as far as all of the vendors being invited to participate on this panel. Just a quick background, we all do know each other as well. We are all part of the HIMSS Vendor Association. It's almost like a little recovery work group when we all do get together and talk about things that challenged us as vendors as much as we try to make things as best for you as our customers as you implement and journey through this course. So just a quick, we have 5 minutes, really brief. I won't even take up that much. They said this buzzer's going to work. Couple of things that we felt as responsible vendors supporting our customers. This was an excellent opportunity for every vendor to really get to know each and every customer. And with almost 1,600 customers from Meditech, which we are fortunate to have, it was also a huge undertaking and a task to evaluate and ensure that we knew where each and every customer was positioned, what was your desire in attaining meaningful use, and everybody wants to attain meaningful use. In our earlier conversations with customers, it really did start out with show me the meaningful use dollars. I think about 2 years ago, that was probably more of the flavor of what we needed to do. As we know, a lot of hospitals probably will keep their doors open only because they can get to meaningful use and get some of these incentive bonuses. And then we saw the gradual change over to say, this is more patient safety. I'm not going to go the first year. I'm going to actually wait an extra year or maybe 2 years and get this done right for the final time. You don't get a lot of second chances. So as far as our vendor commitment to our customers, and I think we all share the same across all vendors, is we really needed to narrow down what is it that you need and how do you get to it and what do we need to do on the background. So we really looked at how many, just a quick raise of hand, show of hands. This isn't new. Meaningful use stage 1, CPOE, documentation. We've been talking about this for what, a dozen years since IOM's report. So we know what we had to do. We had a lot of things already in place. We knew that you needed to have nursing documentation and your departments up to gather this data, as we saw earlier, gather the data. Then you needed to bring your physicians in. Not always easy, the behavioral, the adoption, that's where probably the earlier sticking points to getting the physicians on board. Then you needed a repository for your aggregation. So once you're collecting this data, you need a repository to put this in so that you can report on it. Data collection, reporting, and then of course interoperability. So we narrowed it down. So outside of a big HCIS, what were the key focus things, the tool sets, the functionality that you had to have in place to meet meaningful use? And again, if you look at those key things, it obviously involves the biggest staff, your nurses, your physicians, and your technical for that interoperability and that reporting. So as we moved through this is how we looked at it to say, how do we simplify things for our organizations? Where are you at? Where should you be at in collecting this? A couple of other things. Here we go again. Thank you. A couple of other things that we all needed to make sure that we did for you as well is to be certified. And, well, we thought that's easy. We have 3 platforms to certify. All 3 need to be. Customers are moving forward with each one. And we thought, early days, complete EHR. Well, you know, if you have the EHR, then it's wonderful. You know, choose the pieces that you need or from the menu sets that you're going to select. And then CMS came out with a clarification on the possession rule that you needed to hold or have the entire thing. So we actually had to look at how do we decouple without compromising patient safety so that our organizations who actually did have some other vendor mixes into their HCIS or into their EHR would still be able to attain meaningful use and not have to rip and replace. You cannot start an implementation if your goal was 2011 or 2012. So we then modularly certified, as many of us did, to make sure that, yes, as customers, you were able to achieve your meaningful use and your incentives and stay on the course. So again, just evaluating how do the vendors support, careful analysis of where everybody is, what are the tool sets that you have, what are the applications that you need, and then to make sure that you are fully compliant using a certified EHR. I keep doing that, don't I? Sorry, guys. Not used to a pointer. One more. Thanks. A couple of other things that they wanted us to highlight out. What do we need to do? Well, actually, just looking at some of the expected timelines. We meet up every month at the HIT policy meetings, at the HIT standards meetings. I think we all then run back to our organizations and say, this is coming, this is coming, this is coming, and get to development and get these specs started for what do we need to do. Again, gearing up, looking at where are customers, what is their status. We are hoping that they would have made some better recommendations by now. We're moving into fall. We expected something by summer. So we are expecting actually the proposed rulemaking hopefully by the end of the year, January again. And then obviously the final issuance for stage 2 and what will be incorporated. But let me inform you, we are already working on whatever they have predicted for stage 2, every one of us. And gearing up and how do we help you get that implemented, whether there's a delay or not. So we're really keeping an eye out on that. Couple of other key things that we did to help support and what our roles were is beginning with, for our customers to get to meditech.com, best practices, snapshots. These were kind of the cliff notes of how to get to down and dirty to get these meaningful use functional criteria up and running. The second one was really the best practices for the clinical quality measures. I think the early anxiety over implementing CPOE really passed by when you realized what you had to do for the clinical quality measures, and I'm talking just for the acute care here, in addition to what you already do. So having those practice guidelines set up and how you get those functional and into your system. Also making sure that we educate customers on where to go to find your certified product listing and how do you mix and match. Looking at how you register for the incentives, we had to become intimately familiar with all of these websites ourselves to help educate. Many, many education sessions. Frequently, on a daily or every other day basis, we're looking at the frequently asked questions for updates. So again, I think all of us, as we help to support you in your implementation and your journey into achieving meaningful use, is really making sure that your vendor becomes your partner in doing this. And basically, that's it from Meditech, and we'll see you back out here in a few minutes for the vendor panel. Thank you, everyone.
Thank you, Barb. Our next panelist, Steve Garver, joined Siemens Healthcare Systems a little less than a year ago in a newly created role as Vice President of Strategic Consulting. By way of background, Steve has a finance degree from the University of Texas, Austin, spent 10 years working at Accenture, 12 years at Cerner Corporation. He was a Senior Vice President of Consulting and then spent 6 years as an entrepreneurial CEO, CO, working with a number of startup companies in the Kansas City marketplace. Steve has been married for 25 years and has 3 college-age daughters. God bless you, man.
And that's why I'm here today. No, it's great to be here today, and I really appreciate the opportunity to get in front of what a great group and what a great HIMSS chapter, and the turnout here is just fantastic. I thought I'd spend just a couple minutes this morning covering 3 topics real quick. So I get the forward. All right. Which one, Joe? Yeah, I thought they had me public. It's the right button, huh? Okay. Okay, let me back up. Okay, so I thought I'd talk really about 3 things. One is you all are going through, obviously, unprecedented change, and that's both from an IT perspective, but also from an organizational perspective. And the shift on pay for performance based on quality, the continuum of care changes that you're going to see, transitions of care, the shift to population health management, as well as disease management, and then the amount of collaboration that's going to be needed across provider organizations and across the payer organizations as well is really unprecedented. And the amount of change that you're undergoing today may actually increase over time. It's obviously not just the IT organizations, it's really you all leading the charge across your entire organization and trying to adapt and go through the change management process of changing the way you practice. And we really, I think this kind of change is going to continue. We're not looking at this as just how do we meet meaningful use, stage 1, stage 2. We really look at this from a longer term perspective, and we tend to use the word accountable care a lot, not to be confused with an accountable care organization, but it's really a long-term trend to more accountable care. So what we're doing within Siemens is clearly we've got our regulatory affairs group that's very active in Washington, very active in the vendor collaboration teams, and very, very active in trying to take the regs, understand what they are, work with our product groups to understand the release requirements and product requirements to release technology. But we also look at it from a broader perspective that we have to step up as an organization and look across our entire organization and have everybody involved in this. And we think of it as not just a regulatory affairs and a product set of challenges, but it's the services team, it's marketing, it's sales, it's bringing everybody to the table. And we created an accountable care coordination team that meets every week and spends at least a half a day every week working on a longer term strategy for where we're going over the next 5 to 10 years. Yes, we also ensure that the next set of regs that come out that we meet, but we also spend a lot of time doing thought leadership activities. We have to listen to our clients. We've got to find the folks that are on the leading edge and listen and get out there and visit and learn from your experiences so we can best position our solutions in the long run for you. We have to learn, listen to the industry leaders and really take all that in. And then we've got a lot of change management we have to do within our organization to make sure that we're ready. You can no longer put in clinical systems without making sure that all these kinds of requirements are built in to those deployments. We also have to recognize that we're going to see a lot of other things beyond just the traditional implementation projects for clinicals or revenue cycle. What we're going to see is a lot more projects and initiatives surface that need to be packaged up as projects, and that's something I think that's true on both of our sides. You all need to be thinking of these as projects, and I listed just some of them here under kind of the path to accountable care. Meaningful use is a big endeavor, and you could treat it as a bunch of small projects, but it really can be put under a bigger umbrella. We've done something around the value-based purchasing area. As an example, we looked at industry data in terms of benchmarking data, looking at the workflows that are needed, the assessments, the reports, the alerts, the rules, and kind of packaged all that up, and we're thinking about that as the content or services packages that we can go out to the market with, that we can work with our clients on, so that we begin to come to the market treating these as projects And we just recognize there's going to be a whole series of these engagements that we'll do with our clients over the next 5 to 10 years. And I think that's a kind of a healthy way of looking at it, that it's more than just putting the solutions in. Once you go live with the system, it's almost like giving birth. The fun starts then, and I think there's an opportunity for us to work and to make sure that we bring more than just software solutions to the table, but we also bring some of the services and some of the thoughts on how to get this transformed across your organization and come to the table with answers in those areas as well. So thrilled to be here today, and I look forward to the Q&A afterwards. Thank you very much.
Thanks, Steve. Our next speaker is Dr. Jigar Patel. He is the Chief Medical Officer from Cerner Corporation, U.S. East Coast Client Development. Dr. Patel is an influential and respected advocate of advanced technologies that serve to automate the process of managing health along the continuum of care. He has spent the previous 5 years assisting healthcare organizations and providers of care, understanding the value of healthcare informatics, assimilate the value through their strategic planning and execution of their IT plan. He has a passion for ensuring that clinical information in the electronic medical record is utilized for improving benchmarking outcomes across all disciplines at all points of entry. Dr. Patel has worked in numerous organizations in U.S., Canada, and the Middle East. Dr. Patel?
Thank you, Joe. Thank you very much for the conference. It's been very informative. I have learned a lot of things and met a lot of good folks. So thank you to the New Jersey HIMSS and Delaware Valley HIMSS organizations for inviting me today. So to Barbara, I say ditto. Okay, we are doing meaningful use too. To Stephen, ditto. Okay, accountable care, doing that too. Let's talk first as far as what we've accomplished kind of going forward. I'll give you a couple numbers. 67, 70, 43 million. What does that mean? That's 66 hospital organizations have attested to Medicare using Cerner, 70 for Medicaid. That resulted in $43 million. Already paid. Okay, so it's a big set of numbers. That is, if you look at the overall across the country, that's over half. CMS, last number I saw was 121. So we've got over half of the organizations that have already attested. In our ASP ambulatory environment, we have over 217 that have attested using the platform, 25 in New Jersey. So we're succeeding, we're doing well. We are fulfilling the need for our clients to get reimbursed while there's a handout going on, and that's a good thing. What we have focused on for a number of years we were fortunate in a number of ways in that we have a very forward-thinking senior leadership group, particularly our chairman. And 2008, we started a group that focused entirely on quality improvement. Where did that leave us when the clinical quality measures came out? We were already working on them. And so we've got some very good luck and foresight from our senior leadership that has put us in a good place to help deliver for our clients and capture the dollars that are available for them today. But in reality, well, one thing I'll say about that group of organizations that have attested, that's everything from a critical access hospital to community hospitals to academic medical centers to large IDNs. So we've got 25 beds at Brookville in Pennsylvania, and a number of those organizations doing it and doing it very successfully in a difficult environment because critical access hospitals do have a different kind of look and feel. And so we're very proud of that accomplishment, and of course we will continue to go on and do those things for our clients in the current state. Let's talk about the next, and that's actually the accountable care. Now, back 2009, 2008 timeframe, we had our chairman had a strategic CEO council, and they developed this slide, which is a whole lot to look at. And they basically said, how do we have people be accountable for their health? As a result of these conversations with our clients, we've changed our mission statement, and that's listed there at the top, to contribute to the systemic improvement of healthcare delivery and the health of communities. EMR and healthcare IT, while it is our core business, is the foundation for going and doing bigger, better things and affecting health of the individual across the U.S. and across the world for that matter. You'll notice a number of different venues here: ambulatory, inpatient, emergency department, ICU, home health, retail pharmacy, et cetera, and Cerner covers all of those areas. So we have got a broad portfolio that lets us link all those things together and help coordinate care. So that coordination of care is obviously a lot of things we've been talking about here, and there's some great successes. I sat through the Trenton Health Team discussion panel yesterday, and they're doing great work up there. This is all very, very important, and we've all heard the numbers around why this is hard to do and why we need to do it. And Cerner is definitely working to make those things occur with our clients and with people the other vendors. We want to make sure that everybody's connected and the patient is the most important thing in all of this alphabet soup that we've got going on around value-based purchasing, MU, et cetera. So with that, I'll thank you very much, and I'll turn it back over to Joe.
Thanks, Dr. Patel. All right. Our next panelist is Robin Rayford from Allscripts. Robin is Executive Director of Federal Affairs at Allscripts, where she is responsible for review of government initiatives and their impact on the company's customers and product direction. Previously, she served as a role of Eclipsis. Ms. Rayford closely follows the Office of the National Coordinator for Health Information Technology, the HIT Policy Committee, and HIT Standards Committee regarding meaningful use of EHRs. She's the co-author of the chapter on meaningful use just published in HIMSS in spring of 2011, Medical Informatics and Executive Primer 2, 2nd edition. Creator of the Meaningful Use, The Whiteboard Story, which is a poster summary view of all regulatory documents surrounding meaningful use and the EHR incentive program. Ms. Rayford has served as the chair of the National HIMSS Patient Safety and Quality Outcomes Steering Committee and the Public Comments Work Group, a two-time recipient of the Spirit of HIMSS Award and 2008 recipient of HIMSS Distinguished Fellow Service Award. Robin?
Hi, thanks very much. Thanks for the people who are staying. This is getting thinner by the minute here, so we'll see where we go here. All right, so we have a really kind of condensed period of time here to talk about overview of the company. And I got the directions of what we were supposed to cover, and I go, how did you think I was going to do that? We have 8 electronic healthcare record products within Allscripts. So we have five products in ambulatory, 1 product in the hospital space, Sunrise Acute Care, and in the ED space we have Sunrise ED and Allscripts ED, and a little bit just on numbers as far as volume of what's there. What's interesting about working at Allscripts is between these 8 products that we have 27 versions listed on the Chapel list, because when it first came out that you did 9 quality measures, and then you did more than 9 quality measures for the ambulatory space. Each one of those entries is another entry on the Chapel list. So that's quite the juggling thing to keep up with what version do people have and how many quality measures is in the version that they are using. But it also gives us an opportunity to look at everything from the smaller practices use My Way, which might be a doctor's practice of 1 to 2 doctors. We have 2,200 clients on My Way, which is 5,500 providers. On Pro, we have 4,000 clients, which represent 25,000 providers. Enterprise has 360 clients, which is 4,000 clinics, and 63,000 providers, and 62 million lives are covered by Enterprise EHR, which is EEHR. And then Sunrise Ambulatory has about 15,000 providers on there. So all told, we have of the piece that's out there about 121,000 providers that are eligible for meaningful use, as well as 100 hospitals. We're certainly like the other vendors in that you'd like to know exactly who has attested and who hasn't, and CMS only put that list out as far as exact names once. Now they're into giving a total summary and how much money, where they've said there's been $650,000 passed out in incentive money and over 90 190,000 registrants, and they're keeping up with that total number because they want to be sure that the organizations know, how much money's out there, so that when they start doing the budget thing, they know what's out there. This is just kind of a footprint, kind of little print of what products are out there. So it really is the whole schema in post-acute care as well as community solutions and bringing it together. We did get a question about where we are with health information exchange and how many people are actively participating. And we have really kind of all gamuts of that, from people being in an organization or in a state where they haven't worked out governance yet, and where are they with that. Then there's other exchanges that want to use HL7, which is certainly useful information, albeit it's not semantic interoperability, at least as the data, so you can see it. And then we're beginning to certainly see the emerging of health information exchange that are used in the continuity of care document. So total on all of the products from that previous list, we have 180,000 physicians and 50,000 physician practices and 1,500 hospitals, some of that being our payer and post-acute care products, and then 27,000 clinicians doing home visits every day on our home care products. So really do see the whole gamut of what's there. So in the footprint, in the space of who's got all scripts in the country, you can see there's a heavy dominance certainly in the East Coast, and then as you see that in the middle part of the U.S. as you get towards the West, where there's less population, less populated there. But it is a challenge to keep up with that, and certainly hear the stories and the trials of everyone that's trying to go through that. So with that, I'll give back the microphone so we can get our next speaker.
Thanks, Rob. Okay, our final panelist is Dr. Joe Brummel. Dr. Brummel's role at QuadraMed is Chief Medical Officer and Vice President of Clinical Strategies. Dr. Brummel focused on developing advanced clinical strategy that incorporates best knowledge management practices with innovative technology to improve patient safety. He assumed his position at QuadraMed in August of 2001, after having served as a Director and Chief Architect for Medical Measurement and Management Systems at Cerner Corporation. And Joe, it just occurred to me that I left QuadraMed 10 years ago, so obviously they traded up in Joe's when I left, which is kind of good. With 25 years' experience in healthcare technology, Brummel's achievements include significant innovations in the design and the development of advanced ambulatory and inpatient electronic systems. He is also recognized authority on computerized physician order entry, board certified in internal medicine. Brummel's clinical training includes both internal medicine and rheumatology. Did I say that right?
Yep.
He completed a fellowship at Massachusetts General in Medical Informatics, directed the National Institute of Health, and has earned a Master's of Public Health and Clinical Effectiveness in Health Management from Harvard University. Joe.
Thank you, Joe. If I can get the first slide up, fantastic. In addition to that, I'm just kind of emboldened by Mike Paint, the last presenter. I'm also a blogger. I blog for Healthcare Informatics, and I actually use a lot of Robert Wood Johnson funded research in that. Probably the most recent thing that would be interesting to this audience was a piece on the viability of ACOs. So in the interest of time, I want to thank the New Jersey, Delaware HIMSS chapter for this fabulous event. It's been terrific. I also want to kind of put a bookend on Barb's earlier comments about the EHRA. We work very, very well together, actually multiple times a week, to try to create value for our clients by not reinventing the wheel. QuadraMed's vision is to transform quality care into financial health by connecting people, processes, and knowledge. Very recognizable vision. Some of you may not have heard very much about QuadraMed, so this is gives you a quick chance to read. We have many award-winning products in many different areas. Our clients have earned Davies Awards. You can see the numbers of physicians using the system, and one of the slides, there's a reference to our 25-plus hospitals who are on a certified release on track for attesting. QuadraMed, the quad in QuadraMed is really the four key processes that we recognize: access management, care management, health information management, and revenue cycle. And QuadraMed's unique amongst the vendors in that most of those products have clients who've been using them for 25 years. I think Joe's comments really speaks to that. We've had clients in the 80s. We had several clients live using our ambulatory inpatient EMR, actually using problem lists, doing CPOE, et cetera, in actually several different countries. So there's a lot of maturity and polish in QuadraMed. In the interest of time, how they fit together and the pieces are up there for you to scan. Just an explosion on the care management, just so that you can't walk away and go, well, maybe they don't do CPOE or barcode med administration or documentation, physician and clinician documentation, and have an electronic health record. Quadramed's vision was started back in the actually late 70s, and it was really around integrated patient-centered point-of-care system. The underlined point there is that we actually had closed-loop medication management 25 years ago, when it was very, very early for the industry. In terms of meaningful use, I mentioned those numbers. All of our clients have meaningful use service contracts. As with the other presenters, I think Steve probably went in the most depth. We have meaningful use service contracts, and I'll elaborate a little bit about that. 80% of our clients are moving forward looking at meaningful use as stage one as something that they are going to pursue, most of them in 2012, for reasons we've discussed at this conference. Our meaningful use support includes assessments and content and services in all of those areas. And we were asked to comment on HIEs. We have full support of XDS standards. We are a consumer. We are a producer. We have MPI, identity management services. We have 3 different clients who are exchanging information through HIEs. We can discuss that during the panel if that's relevant. And so with that, I'd like to move on to the panel discussion, which is, I think, what we're all waiting for. Thank you.
Thanks, Joe. Have a seat. I'd like to invite my panelists to come out and have a seat. And while they're doing that, what we're going to do today is we're going to pretend that you guys no longer have a job at your current companies. Instead, you just happen to be industry HIT representatives. So your perspective is not necessarily that of your companies, but now of yours, right? Because you no longer have a job. So no one has a better in-the-trenches vantage point than HIT vendors on the overall progress across many provider organizations in advancing the use of information technology in healthcare. As you probably know, the HIMSS study done prior to the advent of the HITECH Act showed that healthcare was 12 years behind other industries in the use of information technology. Pretty pitiful for an industry that has so much data and information. Where is the healthcare industry currently at in this latest HITECH Act evoked journey? And are you seeing anything encouraging with respect to progress after almost being a year into this program? And actually, we'll start with you, Barb, if that's okay, and we'll go down the panel.
Sure. Well, we do see some encouraging things. Early on, I like to think that high-tech hijacked IT for the hospitals, which is actually a good thing. As I mentioned earlier, these stage 1 meaningful use requirements are really nothing new. We've been talking about CPOE, talking about documentation. You've been reporting it now. It just needs to be seamlessly connected. Again, we feel that moving forward with this is that we do see good adoption. I think I've talked to all of our customers, and everybody does want to move forward with this, not just for the benefits, but the benefits of the incentives, but the benefits for their consumers, us as patients, and keeping them engaged. A lot of momentum is gained, and I think a lot of collaboration is gained, and I think that they realize as we move forward to ACOs that this is just the foundation.
Rob, I'll spin the microphone. There you go.
Sure. So what we're actually seeing too, and again, from what I had said earlier, it is interesting to see it from the solo doc practice all the way through the academic medical center and what people are doing. And what I see, that kind of the flavor of the month that I'm seeing is it's now getting to people that, oh, I'm on that 2012 penalty thing for 1% because I'm not doing e-prescribing, and how can I do this? And I have 1 week to decide if I'm going to do meaningful use and start that next week, so I can claim that I'm doing 2011 that. So I think it's the penalties and the fear of the penalties, which is kind of a good thing. And then in the budget piece for what's moving forward is where they're saying how you're going to self-sustain that is that they're going to end up continue to pay the program based on the penalties they're going to collect for people that aren't meaningful users by 2015. So definitely the kind of the carrot and stick, and people are moving, and lots of it's going to be interesting to see. Watch for the numbers that come out in January for how many people are doing that, because CMS is saying that they're seeing numbers doubling, but you haven't got the late adopters yet, the October to December late adopters. We have a lot of people who are doing that October 3rd thing. In fact, people have said they can't get to the CMS website because it's kind of crashing, like when Target just sold that line of clothes. They can't get to the site.
Great. Stephen, you can pull that closer if you like.
Yep.
Sure.
Okay, from my perspective, as we get this started, and as you say, over the last year, huge amounts of foundational work needs to be done to get there. So even though it may not seem like we've got as much results as we'd like to see at this point, there's just so much foundational work to get to CPOE and to deal with problem lists, and these are complicated issues and topics that have been going on for decades, and we have to get that foundational layer in, and then I think it becomes more of an incremental game where we can be a little more nimble, a little quicker as an industry to be able to move on to the next adventure as we go through this journey together. And so I think this first year, what you're seeing is everybody's active, everybody's working on the right stuff to get the layers in, but it's just not going to be this big crescendo of gosh, we've made it, we're there. But it really is, I think we're going to see in the end, a very, very important year where huge amounts of progress really has been made across all organizations.
Great.
Yeah,
Dr. Patel?
I'll start my comments as a physician. I think physicians, if you look back 10 years and up until 2 years ago, have hijacked IT projects almost across the country and across all of the people sitting here in our respective companies.
Is that sabotage or is that hijacked?
You can debate on the terminology, but it's essentially the same thing. That they have, and I think Meaningful Use has given the hospitals and other people some real financial ROI that can stand up and say, dollars, let's go get them. And then we can get our folks and our physician partners in line. So I'm heartened and think finally we're getting to a point where the foundation is going to be there so that we can do more meaningful things, which is connecting all of our systems and taking care of patients, getting outside of the four walls or the clinic or whatever, and making sure it's more broad than that. But I'm heartened, and I think it's very nice that we're getting adoption across the industry.
Great.
Yes, so I'm a youngest child, and in addition to that, I'm representing Quadrant, which is Q at the end of the alphabet here. So I'm going to be careful to not repeat anything unnecessarily. I think two big encouraging things have come out of this. The first one is that problem-based navigation for the clinicians has become recognized as a critical way to make these systems usable. It's now with the up-to-date problem list as one of the requirements, and with the technology as getting as mature and robust and recognition and acceptance of order sets, which were one of the sources of sabotage or irritation. So I think those things are great, and I think and that's a huge encouragement from all of this, and they fit together with the other two sticky wickets of meaningful use. Most people are finding amongst the elements, there's really three elements that are the most challenging. Problem lists, because we often don't have a precedent in the paper world or in the practice world for it. The second is quality measurement, which has been spoken about extensively at this meeting. And the third is medication reconciliation, which we'll just mention there. How many people in the audience have seen the September 2011 Harvard Business Review article by Rob Kaplan and Porter on fixing healthcare? I see two hands. So I encourage you to take a look at it. The argument is that we have to take a process view and that healthcare providers have not been doing that. And that translates directly into getting more visibility on costs, outcomes, and stratifying that against quality. And I think what's useful about the 15-page article is, first off, they suggest process mapping, which I'm not sure whether that gets you 10 or 40% of the way there, but doesn't get you 100%. And I think that those things are closely, it's very encouraging because we're now moving on to taking more of a management view as opposed to a services view about technology.
Great. And Joe, for the next question, we're going to stay on you, and then we're going to work our way back this way.
Great.
No one feels left out, okay? We realize that you can lead a horse to water, but you can't make him dive. I'm sorry I had to throw in at least one corny AC reference, right? What do you see as the current barriers preventing your customers from taking that steel-pure leap? And what do you see as your role in getting over those barriers, supporting them during this transition beyond just the normal implementation project stuff? After all, now there are considerable AHR meaningful use objectives to achieve post-implementation, as you guys know, to meet the criteria. So Joe, if you could start, that'd be great.
Yeah, so going back to my legacy work with Steve, about a decade ago, there was a comment made by one of our peers that there's 1,000 ways to fail and only one to succeed. which I thought was a phenomenally depressive, non-motivational kind of a way of looking at it. But the person who said it was actually a very, very upbeat, positive person, and his point was that you really have to attend to all the details because the one you don't attend to is one that can kill you. And so I think that that's the biggest challenge here in terms of Dr. Patel's comments about representing physicians and hearing what they're doing. For them, you've got some of the old dramas. You also have more of a move toward hospitalists now, which make flows a lot easier. And you also we've evolved to younger physicians who have different expectations. So I think the attention to details is really the thing that's separating out the people who are succeeding from those who are just continually tripping and getting bloody noses.
Dr. Patel?
So I think the biggest barrier is partly hospital culture, in that we as suppliers and as a government are moving very, very fast. And the culture of hospitals is to not move fast, which is problematic. I see some nodding heads here, so they're agreeing with me. So culture is a big thing. We are in an entrepreneurial world, in a world where we are moving fast as suppliers and trying to move faster. Everything is move faster, move faster, move faster. How do we help our clients move as fast as we want to go? And in this era where you've got 2 years to get to the next stage, that's a big project. And then you've got 5010, and you've got ICD-10 coming, and you've got all these things that are piling up on top of each other. And an agile business model is not something hospitals have ever thought they would ever need, and that's a problem. So that's my comments.
Nicely put.
Well, and I think of this more as a business challenge and a business problem than an IT problem. And I think you all probably face challenges every day. Is your senior management lined up? Are they all on the same page? Do you really have a 3 to 5 year roadmap for where you're going or where you think you're going? And I think this is a little bit like sailing. You have to tack to get there. It's not like you can draw a line out here and say we're going from here to here. You've really got to look at how you attempt to hit it, but you're going to have to kind of adjust and do some mid-course corrections to get there. And I think I would challenge you all to make sure that all of your IT strategic plans, again, are well tied into the business plans. And you're going to have to be the leader sometimes, I think, forcing some of those conversations to be had, because it's got such a big impact on where you're trying to take the organization. And as we all know, once the bright ideas are agreed to, it takes a long time to actually then go execute on them. And I think that's something that the industry is going to have to keep working on. And it's going to be a challenge. It's just, this is hard. All the regs aren't published, aren't all out there. It continues to evolve, and we just have to stay current continually.
Right. So I would certainly agree with what my colleagues here have said. One of the things that we can definitely see in a barrier piece is so that when people say meaningful use and they kind of look at it as one thing, like boil the ocean, and you really have to get it down to CMS, the program, what are you supposed to do? What's the project? How do you have to do to put certain products in place, certain modules in place? What do you have to do? Then a huge, big piece, bigger than almost anything we've ever seen, is the process workflow that you've got to follow to capture the right amount of data, to capture the stuff you need to put in your reports to CMS. And put that whole thing together. And I've always thought, when you hear people say meaningful use is somewhat of a piece of cake till you get to the quality measures, that is another beast all of its own. When you start talking about the exclusions and capturing that, the people that threw their arms up in the air, that we can't do this because it was palliative care. Now all of a sudden they've got a documentation thing, that you're forced into a documentation thing, that you want to give everybody a copy of their health information. Oh no, well, you got to capture it was on request, and that you met that request within 3 days. So now all of a sudden that pushes you into a process flow. So it's a good idea to at least, it's all meaningful use, but you need to take the process, the program, the project, and all of that together and keep them separate and address each one individually.
Great.
Well, I too will certainly agree with my colleagues, and I think Dr. Patel noted the physicians sometimes hijacking some of the projects and not agreeing to the technology. So I would probably say one of the biggest barriers still remains is cultural changes, behavioral changes. And luckily we are getting into, I think, a generation where the docs are coming out, they're used to IT. The nurses are coming out of school. Most of the nursing schools now have IT in their curriculums as well as the physician programs. So we hope to see that change. I think another big part of the barriers, and Steve noted this as well, is it's a business plan. The paradigm shift in how we provide care is moving to the home. And how do you shift your business at the hospital to become outpatient-based and have your chronic disease management set up so that you do avoid these readmissions, so that you do keep your population healthier? That is what you're going to be graded on. So it is a business plan, unfortunately. Healthcare is scary. We're all afraid when we go into the hospital. So, 15, 12 years behind adoption of IT is not surprising. And really gearing up to realizing it is a business as well as it is a caring business is the behavioral changes. It's the cultural shift that we're all going to need to see.
Great. We're going to change this up a little bit, Steve. I'm going to let you answer this question first. And you guys kind of already alluded to it in some of your open remarks and even some of your questions, but we're going to drill down now. Looking at the data that CMS issued back in early June of this year, it showed that EHR adoption attestation, however you want to say that, in terms of people saying, yeah, we're going to go for this, was only 20% of where the CBO, the Congressional Business Office, had projected it would be during the first year of the funding cycle. Are you seeing that as well, or it's just a circumstance of hospitals giving or providers giving themselves more time to implement and get up to speed and figure out stage 2 and all that business, so they can ensure they meet these objective thresholds? And if that's the case, then do you expect in the last part of the year they're going to see gangbusters, and then here on we're going to get into warp speed?
Great question, and it's interesting you use the 20%. I did some of my analysis. We solicited information from all of our clients, and as we look across that data, we're at about 20% that we see attesting in 2011. Maybe no surprise. But there's a nice bell curve. We're seeing 60% want to go in 2012. So again, maybe it's back to that comment of significant underpinnings are going in 2011, 60% adoptions planned in 12, and then beyond, we've kind of got the last 20%, and that may be a combination of some folks in 13 and then some folks with unreported data or aren't there. But I think what's important is we really have to figure out how to hold that 60%, so we're 80% over the next year, and I think that gives us a big shift to be where we want to be.
Okay. Rob, off you go next.
So I would say, too, that from a perspective of when people are waiting and see what they're doing and whatever, I usually say when I give a presentation, I said, if you're waiting until October 1st, 2013 to mix Loink, SNOMED, and ICD-10, you are a risk taker. You are a risk taker big time. I cannot even imagine trying to get a doctor to comply with Loink, SNOMED, and ICD-10 in the same year. I don't care what kind of matching engine you have, that's really a difficult thing to do. And it is pushing us into this whole thing of semantic interoperability, where we call the ramifications here that we have in our future, and some of the speakers that were earlier today, of where we can go with population health once we're all calling this MRSA with a code, not depending on who's done what in an item catalog and order entry and what they've made it happen. So, we're on a journey. We're on a journey to make it better, and I do think we are going to see the crash the website stuff that's going to happen. I had someone tell me the other day they had 600 physicians to register by proxy registration. It took them 8.5 weeks to get everybody registered with 3 people. So if you're doing a lot of people, I even had one person screaming at me they were going to do 1,000 people and they were going to test all on the same day, and I said, with one person? I don't think so. They haven't read that. So be careful in your timing that when you do this, because I do think you're going to see some crash the website stuff, of people waiting to the last minute doing what they're doing.
No, agree with that, especially as you see, we've done careful analysis, and I think in the earliest stages with our customers, we actually put them into groups. Group 1, you're ready to go. You have all of the tools that you need in your arsenal for your EHR, except all of a sudden you got the clinical quality measures that kind of popped up and reared their ugly head, and how do we retrain and get that data captured? And then we had group 2, and then we had group 3, and then we had those that hadn't really thought about it but thought they're just going to go for it all together at the same time. So we did see some laying back because, again, they redesigned their focus for patient safety and the quality and wanting to get this done right. You don't get second chances a lot of times in implementing this. So, again, stepping back and looking at that. So we did see probably about 20%, 25% of our customers. We'll see the numbers jump, certainly when the next reports come out, and certainly by the end of the year. And we do have that huge bell curve in the middle there for 2012, where everybody's ready. And again, those stage 6 customers, as you can tell by HIMSS EMR adoption rates, of course, are going to be always your earlier in the forefront. But so many of them are climbing up, and we'll see a lot more participation in that as well. So it's a good momentum. I'd like to make sure that we keep it going, and I think everybody's really jazzed about it, that if they can get in 2011, 12, and 13, is that they're really geared for, you know, that at that end, that ACO in the end that they need to get to.
Joe?
So, yeah, Quadrament's a little bit different kind of a company in that we've had an EMR that people selected who wanted to do CPOE and problem lists and whatnot, again, 25 years ago. So we're anticipating about 80% by 2012 will be attesting to meaningful use. But I think there's a couple of other points that are kind of worth mentioning. One is, so I'm from Washington, D.C., and I'm here to help you. I live in Washington, and there's clearly there's clearly going to be more twists and turns along the road. I think what I learned at this conference that I didn't have prior was that there's that the meaningful use incentives are a tenth of what the losses will be if you're not able to operate as a meaningful provider going forward. So I think that the industry is likely to do much more. And I think, lastly, I think I want to tie together some comments that we're all making about culture here, which is that we're moving from an era where most physicians were selected because they were lone warriors. That was they were selected for and working at that, and also many hospital administrators, many CEOs were at this level 3. In order to do the kind of collaboration and interoperation to actually do the quality measures, the process mapping, the change we're talking about, you really have to move to level 4, which actually requires moving to triad relationships instead of dyads. And so there's a lot of people development that is happening along with this that makes the numbers in a way irrelevant, because we're moving forward and culturally in a way that will let us get to 100% easily.
So just kind of start back at the CBO and how their estimates missed the mark. That, again, it's definitely culture. That's different. We have a different culture in healthcare than pretty much every other industry, and so their estimations were based on other industries, and then that failed. So that's probably why we're seeing the wrong numbers. I'll confirm with us, in our estimates, we're going to get to 80% in the next couple years. Like Joe, though, we built a clinical system, and we are very upfront, and we've been doing these things for a long time. It's the hijacking and the I don't want to touch the computer, and then those other things that we're dealing with more now, and then the reporting is obviously, and it's only going to get exponentially worse. It's 3 this year and then 10 next year, and I'm making numbers up at this because we don't know. 3 and then 50 and then 100, and it's just going to keep going up. So it gets back to how do we make sure we're agile internally and in our hospital, in our development, and what's coming, to make sure that we can do those things as expeditiously is very, very important. The culture of physicians is obviously changing. More and more of them are just ready to get a paycheck and practice medicine. They don't want to go and worry about running an office and have their wife do the billing and all that. They'd rather do those things, go home, sleep comfortably in their bed, and know that their patients are being covered by the other hospitals who's in the hospital, as opposed to picking up the phone in the middle of the night. It's very, very important and different than in the past.
Now, I did prepare one more question, but you know what? You guys look like you're really chomping to ask questions. So, and I'm sure your question is going to be a lot better than mine. So if you don't ask questions, I'm going to go to it just to threaten you here. So at this point, I'd like to open it up. If anybody has a question, I don't know if we'll need a mic since we're so open. Do we have a mic, Tony? Yes, we do have a mic. Oh, great. So if anybody would just raise your hand, and we'll get a microphone to you, and you can ask your question. No questions? Don't make me go to my question now. I'll throw my question out. All right. We're flexible here. Okay, so we've heard a great deal already this morning that helps us understand the important journey better. But as you know, the nation is expecting to spend close to $40 billion in taxpayers' money when it's all said and done, and they're expecting to get half of that back in projected savings and so forth. what do you think will be the first significant result that we'll all see as a nation that starts to convince a lot of these skeptics where they state to say, hey, well, maybe this high-tech money invested in EHRs just might have a positive impact on patient safety, quality of care, and cost reduction. That is worth all this investment, which, as you guys know, it's significant. Or do you see it playing out differently with respect to success or failure milestones? And if you could explain what your perspective is on that. You know, it's kind of like that turning point, right? When people say, ha, it's working.
I'll go first since I'm at the end
Okay.
here. Well, I think that there's been a lot of evolution of consumer technology through the web services, buying things through Amazon. You know, I think someone mentioned yesterday or today, you don't ever go to the store to get a DVD or rental anymore. It doesn't really make any sense. And I don't think people stop and say, gee, that was really worth Netflix investment. So, you know, already I'm getting, when I see my physician, I'm already getting a printout from their system, and I'm getting my prescription sent electronically, and so I'm starting to benefit from this. I think the thing that I'm most excited about is being able to get my labs directly electronically, which, as you all know, this is rapidly coming. So I think that in the same way that that global positioning systems, GPSs, they now, most of them now give you traffic information, not just directions. People don't stop and go, gee, this GPS stuff is getting better. They just expect everything to be getting better, and they take it for granted. I think that's going to be the predominant model.
I think we'll see the paradigm shift come, like Joe has mentioned, that you are seeing all of these things that we never thought 10 years ago. I would be watching movies on the internet, and that's my only way of getting movies. Nobody thought that. It's the same thing in healthcare. We, for a long time, said the doctor's chart's over there and the doctor's chart's over there. And I think the tipping point will be when the skeptics get sick themselves. And they end up in a hospital or in a clinic, and their doctor doesn't know what's going on, as well-intentioned as he or she may be and as smart as they may be, because his record is somewhere else, or her record is someplace else. I think there are more and more of those stories that are coming out that are going to turn these skeptics and really get them to realize that, you know, the sharing of information is going to be really, really important. Cost saver, you know, the litigation thing. I think an added benefit that will occur as a result of this is litigation will go down, because people will get better information and they'll be making more informed decisions, and as a result we'll see some change there. Which is, again, probably something many people don't think about as a result of this, but I think that will be one of the things that may come out of this.
Well, I think we're going to continue to see a level of collaboration within organizations, but also outside the walls of the organizations that are going to continue to rise. That's going to be a real offshoot of this. We had an interesting meeting the other day. One of the major payers came to visit, and we sat down and talked to them. Their premise for coming was the person that was in charge of the ICD-10 program for a major payer organization. He had a $500 million budget to deal with ICD-10. Wouldn't you all love to have that? He was very, very confident they were going to hit it from their end and they'd be ready early. Very, very concerned, though, about the breadth and the mix of all the provider organizations, and would they be ready, and would they be ready together so that it was a smooth and hopefully a ventless situation when the date hits. And in going through that, they were looking at how can we test early? How can we get to the provider organizations to figure out how to make this smoother? The worst possible thing would be in the ICD-10 world that you don't get paid, and all kinds of things then unfold that would really, really be bad. By the time we left the meeting, we had switched to not just talk about that, but really to talk about disease management, population health. How do we work together, and are there ways we could work together to really begin to think about those from a much, much broader context? And so I found it to be a very, very enlightening meeting to listen to that perspective, to think about the fact that they actually want to begin to collaborate. And in the end, I think we've got to bring the whole ecosystem together, and these kind of things, hopefully in the end, will be the result that we see a much better system.
So I would like to chime in and agree that as people that are naysayers now have They might be naysayers because they've never had an event in their lives where their parent was harmed or their child was harmed or something because the right information was not at the right time. I would say as a clinician, this has happened to me in that there is nothing like it when you realize you got a piece of data that wasn't really, you didn't think would be there. It was there, and because you had that piece of data, somebody lived. And I will tell you that I did a phone triage for the Kaiser Permanente 1-800 line, which is a risk-taker kind of job that you're going to pick up the phone and you have no idea what's on the other line, especially the 1-800 line, because people call Kaiser instead of calling 911, and you're thinking, oh gosh. And someone screamed, it was screaming on the phone, this man was gushing blood from the waist down. I go, men don't gush blood from the waist down. What is going on? Women do that. Men do not do that. I started thumbing through the record, this is about 15 years ago at Kaiser, hoping to God I would find a piece of information that was there. That man was 5 days post FemPop bypass, his femoral artery wound dehisced. He was shooting blood to the ceiling in the dining room, and I realized that this man is going to be dead here in about 20 minutes if we don't get there. We ended up getting a helicopter to Walmart, an ambulance getting to the helicopter. The helicopter got him to the hospital. He lived. If I had not seen that, I never in 100 years would have guessed he had a FemPop bypass. And that's the power of somebody having that experience or having that happen to their family, or maybe their family died. Watching Congress, what happens if hopefully Gabby Gifford gets to be able to come back to Congress. That was powerful when she came back in the middle of her long-term care event from being shot, you know, of what that will do to legislation around long-term care. So it's these personal events that drive people to the energy to keep going on. I agree that's going to be a pivotal point.
And again, I thought long and hard on this question, and I think that the efficiencies that we will see, that we'll see early is, as a society, we're getting better. So technology gets better. Patients actually are willing to adopt this. They're actually wanting access to their medical records. Physicians are getting a little easier to work with. I used to run a clinic, and access to information would be that I had a key to his door to go home and get the records he took home to dictate when he was on vacation. So just, again, having access, I think education and collaboration, because this is moving into, you're right, disease management. No one should own the data. It should be ubiquitous. It needs to get to public health reporting so that we can take better care of the population at a whole, as well as making sure that education. I liked one of the one of the criteria is that providing patient discharge instructions and patient-specific education. And it was funny, I thought that would have been easier because every time I've left the hospital, I always got a sheet. But now they're actually paying attention to make sure I do have something in our hands and that we are a little bit more educated. And we're looking at more innovative ideas of how hospital systems can do that as you're leaving your outpatient setting. I go to the veterinarian's office and I bring my dog in and they put a screen on. There's a picture of Riley the beagle, and they put on the weight management education session for my dog. And this is what we need to do for us. I mean, before I'm leaving, is like I want to see something visual and interact with it. So again, I think it's education, it's collaboration, and it's making sure that that data is ubiquitous to have it at our fingertips. I think those will be the efficiencies that we do see.
We're just about out of time, but because you guys hung here to the bitter end, although it wasn't so bitter, guys, thanks. What we'd like to do is share with you something, and Robin, will I get our presidents to bring it out and show unity? If you could describe what we're bringing out.
So I grew up in Las Vegas, so I actually think this is a hoot to be in this room. And I said, well, you all came to Atlantic City, and maybe you didn't do good in the slot machines, you didn't win anything. And I said, we really ought to give people a prize for staying till the end. We'll push this to everybody who came to the conference, but most people won't open it because they won't know what it is.
So you can get a camera
So this, I don't know if the camera can zoom in just on this top row right here of gray, of what's here. Here's a summary of about 2,000 pages of federal documents of exactly what you need to know as far as eligible professionals in hospitals, what's the measure, what's the numerator, denominator exclusion, what's the certification criteria, and what's the standard. And it's grouped by how you attest. And this is what you have to have for electronic copy of information. This is what standards you have to have. And then this is what you have to certify it. So it'll save you reading about 3,000 pages of stuff. And because you stayed to the end, you know this page exists. So we just want to pass that out to you so you know.
So where can they find this, Rob?
I'll give it to you and you'll push it to them or something.
Perfect.
Yeah.
Perfect.
If you actually, this is kind of funny. If one day I usually travel with this, it's printed on vinyl, and one day I didn't travel with it. And so I Googled the name, meaningful use whiteboard, whiteboard being one word, 2 million hits. So if you ever forget it, it's out there.
Thank you. With that, I'd like to thank my panel for doing such a great job and coming together in a spirit of unison here. So if we can give them a round of applause, that would be great. Thank you.